All right. My chair, is my mic on? Ladies and gentlemen, thank you for being here. We are going to begin. It is 2:04. We have well more than a quorum, and we just added a new one. All right. We are going to begin. That's right. And we are going to begin. We're going to take up, we're going to vote on, ostensibly, on 3 measures today, and here on another. And we're going to begin with Chairman Hawkins, House Bill 1520. Chairman Hawkins.
Thank the committee. I bring before you today House Bill 1520. This bill, as you see it in the header, creates the Georgia Council for Addressing Healthcare Workforce Challenges. Our workforce has been decimated by COVID. Of course, we'd had challenges even before COVID. We're a fast-growing state, and for us to keep up with healthcare, we have done a number of measures like increasing residency slots, increasing funding for nursing schools, and a number of ways to address this. This council is going to take a hard look at the future and what we're facing right now, especially after COVID, and in the future. We're going to look at all aspects. You notice that we've got a 26-member council on this. We'll be breaking up into subcommittees to look at a large span of issues in the state and come back with some recommendations. It's a broad council. It's a good council. We've got educators on there. We have providers. So I know we did not include everybody in healthcare and wish we could, but when you get to be a council of 26, that's a pretty big council already. But we are going to be listening to the different groups that were not involved with this and listening to their issues and addressing those as we break up into some of these subcommittees. So that being said, we've got a number of people who want to speak to this. If there are no questions, I'll let them get up and speak.
Mr. Chairman, I would just, first of all, tell you I appreciate, you spoke to the size of the size of the committee, and of course, you're right. You have to keep it manageable, but I do appreciate that you've got a broad cross-section herein, and institutional and community-based, et cetera. Right. And so I appreciate that. Right. And I do want to go to, is that Representative McLeod there for a question?
Thank you, Mr. Chairman. So I appreciate this bill, and I actually the nurses were out here this morning, and so like I said, I appreciate the bill. I also want to one of the things I hope that you guys really take into consideration with when you're studying is the way nurses were treated, these frontline folks, with the push and the negativity that was created around nursing. And these are people that were given their life and taking the time to really try to save people.
Right. And
they were demonized.
Right.
We've got to stick with science and data and facts to making sure that we create a healthcare system that actually works for people. So I hope that that is part of the plan in this bill.
Absolutely. You make a good point, and thank you. Our nurses deliver a large majority of the health care, obviously, in hospitals. And they did an unbelievable job hanging in there during this crisis. Unfortunately, some of them have not come back. They got worn out. But hopefully they will. But thank you. Believe me, we'll be looking at that for sure. Okay, well then I'll sit down. In fact, if you don't need me,
hold on, Mr. Chairman. I
may run to another committee.
You just hang in there now. All right. Representative Robichaux.
I just want to make a comment. What I really like to see too is not just the educational aspect and those of us who have clinical backgrounds, but also to see that you're including the division for licensing, because I think again we can educate and train. We also have to make sure that licensing within our state allows our practitioners to practice at their highest level capable. So I'm very happy to see that in there also.
Well, thank you for the comment. Yes, we need to look at all aspects of how we increase our workforce, but also at the same time provide a quality workforce.
Representative Byrd.
Thank you very much. Thank you for your bill. I'm just curious to know, are we also, while you're studying of this, for this new council, the discussion for those individuals that choose not to be mandated to take a vaccine?
I'm sure that subject will come up, but the focus of this is to make sure that we think, for now, the present, and especially in the future, the workforce we have to take care of the people of Georgia. And that's going to be our main charge here, but I'm sure that issue will be brought at the same time.
Okay, yeah, and Mr. Chairman, just to be clear, I think we've discussed this in this committee for quite some time now. We have some really serious workforce shortages, not only with direct care staff in this state, nurses, almost everything that touches healthcare. And so that has certainly been exacerbated by the pandemic, and we appreciate you bringing this measure. We will go now to those that want to speak to this bill. I believe we have Terry Rogers first up. Oh, I'm sorry, wrong bill. I apologize. Scott Steiner with Phoebe Health System. And please introduce yourself, folks, when you come up. Introduce yourself before you make your remarks. Thank you.
Good afternoon. My name is Scott Steiner. It's my privilege to be the president and CEO for Phoebe Putney Health System. We serve about 1 million people in Southwest Georgia, small urban and rural communities. Chairman Petrie, thank you for the opportunity today to be here, committee members, and thank you, Chairman Hawkins, for authoring this bill. The healthcare community also appreciates your consideration of House Bill 1520. I'm here today to talk about a crisis. Crisis is a word you've heard a lot in the last couple years, especially in healthcare, with COVID introducing us all to crises on multiple fronts: bed shortages, drug shortages, equipment shortages, and of course, staffing shortages. The staffing shortage is the one crisis that predates COVID and the one that continues to accelerate. Simply put, there is a severe shortage of nurses, pharmacists, and other health professionals nationwide. Here in our home state, Georgia ranks 45th in nurses per capita. As I stand here today, we currently have a statewide shortage of 28,000 nurses to just be at the national average. That is just to get us back there. And that number is set to explode to an estimated 50 to 75,000 unfilled nursing positions in 2030. Recent studies show that the deficit of healthcare positions, particularly in nursing, negatively impact care and compromise patient safety. Soaring competition in the current labor market has put a massive financial burden on healthcare organizations, especially for small urban and rural hospitals throughout our state, already having to do a lot more with a lot less. In a recent study by the Center for Healthcare Quality and Payment Reform, just out last week, 892 hospitals across the country are currently at risk of closure due to the financial losses and compromised financial reserves. There are 26 in that report identified here in Georgia. That represents 43% of all rural hospitals in our state. Another recent survey of over 200 bedside nurses showed that 90%, 90, were considering leaving the profession within the year. These are people who have devoted so much time and energy, dedication, passion to their education, their training, care delivery, and to their patients. But the stress of the shortage has caused them to consider these drastic measures. Add to the urgency is the lack of available nursing slots and faculty to instruct at our colleges and universities. Last year, 4,400 qualified students who applied to nursing programs in Georgia were denied access. There just simply weren't enough slots or faculty to educate them. It's clear that we need to meet this challenge head on. It's clear we need to act with urgency and purpose, and this bill and the establishment of this diverse statewide council is a critical step in that direction. We need to leverage the best and the brightest in our state to begin reversing this deficit trend. It takes a collective effort. No one person, or team or system can solve this crisis alone. We can't expect to effect change working in our own bubble. Instead, we need to embrace the power of partnership. We need to cross-pollinate. We need to collaborate. Great ideas become that much greater when they are shared, challenged, and honed by a collective group. And House Bill 1520 will create a uniquely qualified group of brilliant, dedicated, and experienced healthcare professionals with one common goal: to create more Georgia nurses and other healthcare professionals. This bill will bring together leading thinkers from across the state, bright minds from our university, college, and technical college systems, as well as K through 12 educators, frontline caregivers, and medical facility administrators who know firsthand what our nurses and other healthcare heroes face every day. Representatives from nursing, hospital, and medical workforce associations that can help us understand what our future clinical staff need from us to stay local, inspired, and engaged. And of course, members of our local and state governments from both public health and from the legislative ranks to help us shape policies and enact programs to tackle this crisis head on. We are in the midst of a crisis, but together, in partnership, we can create a solution. Together, we can attract and inspire and empower the next generation of Georgia healthcare heroes so that they can channel their passion into a career of caring. Together, we can build the most qualified and robust workforce in the history of our state and our nation. Together, we can emerge from this crisis stronger and healthier than ever before. The time is now, and together we will rise. Thank you, Mr. Chairman.
Thank you, sir. Next up, Ms. Anna Adams. Okay. And Anna, if you'll hold 1 second, I missed a question from Representative Benton.
Thank you, Mr. Chair. You probably need to come back over here to the microphone.
I apologize.
Appreciate you being here today. It's a long drive today.
No problem.
In your talk, you said that 28,000 nurses short. We ranked 45th. Before COVID, what was the shortage and where did we rank? Do you know?
You know, I don't know that. I've been in healthcare for 32 years. We have always been short of nurses. There's never been a time we haven't been recruiting. It's just been accelerated.
Well, other states have got to have the same problem we do.
Well, they do. There isn't a state that has a surplus of nurses.
Okay. All right. Thank you.
Yes.
Any more questions from the members? For Mr. Steiner, any more questions? Okay. Thank you, Mr. Steiner. And now we'll have Ms. Adams.
Thank you, Mr. Chairman, members of the committee. My name is Anna Adams. I'm with the Georgia Hospital Association. We represent more than 160 hospitals across the state, ranging from large urban to small rural facilities. And we come today very much in support of House Bill 1520. We appreciate Representative Hawkins for bringing this forward. I can tell you that throughout 2 years of COVID and all of the questions that we've gotten from our members, workforce seems to be the #1 issue that our members are struggling with. And I'd just like to highlight, when hospitals are struggling with workforce, that means shutting down services. That means we're no longer going to offer OB. You're going to have to drive further to have your baby, et cetera. And so as we're thinking about these challenges, it's now clearer than ever that we need to have everybody at the same table, having the conversations with one another so that we aren't working in silos. And I think that this bill really addresses that from a comprehensive point of view. We really wanted to kind of model this after the Georgia Behavioral Health Reform and Innovation Council, and out of that council and the work in those subcommittees, we saw House Bill 1013, which is really aiming to address our behavioral health crisis in the state. And I think we can see from the work of that committee what it looks like when a lot of experts put their heads together and work toward a common solution. So very much would appreciate your favorable consideration of this bill, and I am happy to answer any questions that you may have.
We do have some questions. First thing I want to say, Ms. Adams, is you are correct. Not only the hospitals, but being on health and health appropriations and this committee, I can tell you every provider the number one concern they have,
Yes.
workforce. So it is a recurring theme. All right. Representative Bruce has a question first.
My background is human resources, and 30 years of it, a good portion of it was with Burger King Corporation. I was head of HR for the whole corporation. And I can't think of anything tougher than getting people to work in a fast food restaurant. Nobody wakes up and says, I cannot wait to go to work at Burger King. And but turnover is expensive. And so we had to come up with creative ways to do things, to hire people and get them to stay. I suspect that you're going through the same thing with your nurses. But what kind of creative things are being done that are out of the box, so to speak, that will recruit people and keep them there in that profession? What kind of things are you guys doing?
Yeah, so that's an excellent question. In addition to recruiting new nurses, we do need to focus on retaining those nurses that we have. And a lot of that, to Representative McLeod's point, these nurses are burnt out. They feel as if they have been demonized in certain scenarios. And so, I think you've seen a lot of acts of appreciation toward nurses over the last 2 years, but it really seems like that is not enough. And I completely understand, that feeling. We've got a lot of hospitals that have been doing what they can to provide financial incentives to these nurses to keep them in the community. But one of the added challenges that we've seen at the hospital level is that many of our nurses are leaving the hospital setting to go and work for an agency. And so as hospitals are trying to keep their workforce at a level that it's acceptable, that's safe, they're having to hire these agency nurses at 2 times, sometimes 3 times what we would typically pay on an hourly rate for this staff. And so in thinking about how we keep these nurses from leaving the setting of a hospital to go to an agency, we are having to come up with creative solutions. And right now I don't have all the answers to that. We're looking at what other states are doing, but I'm really hopeful that this council will be able to kind of dig deep a little bit, ask the nurses what it is that would be helpful from an incentive standpoint, and start to implement those statewide.
Mm-hmm. Can I, just as to offer something, one of the things that we did was similar to what you just said. We got the employees and we asked them what it is that they wanted. We found that they were working for different reasons. And, some of them were working, they were in school, they wanted to just have money while they were in school to help pay their tuition, et cetera, et cetera. So what we did, we put a pot of money together. And it was, a couple $1 million, whatever it was. And we let everybody design their own benefit package. And part of the benefit package was that you could put X amount of dollars aside for each year that you were there, but you couldn't get it until, we went through a measurement to see how long it took us to make a return on the investment.
Like a vesting process.
Yeah. And we found that, if somebody was there for 4 years, 5 years, then we made our money off of them and it was fine. So that's what we did. And what was happening is that they were able to see that money piling up, and they didn't leave because they wanted it. And in some instances, it was, $5,000, $10,000, $15,000, and but they saw it. But the point is that you got to just come up with some real creative things, and sometimes the best way to be creative is just ask people what they want.
It sounds like you just signed up to be one of the speakers for the commission.
Representative Benton.
Thank you, Mr. Chair. Glad to have you with us today. What would you say is the number one reason that hospitals cannot hire or cannot get enough nurses to come and work for them?
We don't have enough. So it's a finite resource. It takes, years to graduate a nurse from a nursing program. As quickly as we are seeing nurses retire, leave the field altogether, we just can't replenish it fast enough. And so, as Mr. Steiner pointed out, when we don't see the number of graduates every year to replace those who are leaving, we're going to continue to have this issue until we expand our educational resources.
Follow up, Mr. Chair. I was contacted by a constituent whose child was in the nursing program, and because she was not willing to take the vaccine, nor were any of the people in the nursing class willing to take the vaccine, they were denied the clinical, which would be that many nurses that are not out there.
Right.
Do you have any alternatives for people like that?
So the vaccine requirement from a hospital standpoint does come from the Centers for Medicare and Medicaid Services. So that's a federal mandate that we have from the federal government. There are exemptions allowed for closely held religious beliefs and for situations in which the patient's physician feels that it's not in their best medical interest to have that vaccine. Hospitals are creating, forms for people to fill out, ways that they can apply for those exemptions, and doing their best to make sure that they are providing enough flexibility in those scenarios. But I'm not sure if in that particular situation it was a requirement of the school or of the facility that she was going to work in. So that,
From what I understand, it was a hospital.
yeah, so that would be CMS.
So that was a whole class of nursing students that I don't know what they ended up doing on that. But if they can't do the clinical,
Right.
they're not a real nurse.
Right.
So
And we have made, that recommendation through the American Hospital Association at the federal level that this does present some challenges for us when we're thinking about workforce development and workforce growth. And so we continue to have those conversations, but at the federal level, it is slow moving.
do y'all lose a lot to nurses leave the hospital and go to work for a doctor's office?
We do. It's better hours. It's more predictable.
And a lot of those doctors work for that hospital.
It's about half and half.
Okay. All right. Thank you.
Yes, sir.
Thank you, Representative. And I do want to say that just to the issue of us producing more nurses in this state, I do want to make it clear that on health appropriations and our governor and his budget, we are on that issue like a rat on a Cheeto. So that is first and foremost job one. Representative Donahue.
Thank you, Mr. Chairman, and thank you. Love our nurses. And Representative Benton brought up a part of what I was going to say. I had the same problem with the technical colleges, and several people reached out to me. And I've had several conversations with Miss Deb Bailey, is always available. And I always mean this. I appreciate you even when I don't agree with what's going on. The biggest problem was we needed the religious exemptions and the medical exemptions. And I have fought for this over and over and received thousands of calls, not 5 or 6, but thousands. And when I say that, I take it serious. And I had an immediate call the next day on what Representative was talking about, that we are going to allow the exemptions again. Most of these are nurses and doctors, and they're tired of someone telling them it's mandatory to do something. And I do appreciate everything you're doing, but we have to keep that in this bill, whoever this committee is, or it's going to get worse, because these people finally, they said, what would you do? And I had to tell them, I'm not an attorney. I'm not going to tell you what I would do in your shoes, but you asked me, I would walk away. I would go, well, I work for $35 an hour when I can go work for $160 or $170. But I said, that's really not the right thing. You went to school to become a nurse. And most of the time when you're in nursing school, you have to pretty much make a top grade. That's still the standard, correct?
Yes.
So you lose a lot of people there. But I've had people that have reached out, instead of working 7 days a week, they can work Monday through Friday. And I understand all that. And we do need the process to work, but we can't have bullies pushing these people, and that's what they're tired of. And I'm just being transparent here to tell you that we have to keep that there. And if we don't, it's going to get worse, and we can't keep throwing money here at it. So we need to learn from that curve, and the governor stepped up, the attorney general stepped up, and the judge said it was unconstitutional. So we need to remember that every time we make a decision, because I'm not paid enough to keep talking to these people over and over and over, and I'm not an attorney. So anyway, thank you, and I do love our nurses. I wanted to be positive on that, but that's the biggest thing that y'all need to hear continuously.
Thank Thank you.
And
We
thank
appreciate
you.
your support.
Representative Gamble.
Thank you, Mr. Chairman. I would just say that I think that the single greatest potential for workforce and healthcare is in our K-12 pipeline. And I know that y'all are involved with our healthcare science programs and our Health Occupation Students of America, wonderful student organization. I just don't ever want to miss the opportunity to mention that, because sometimes in our focus on K-12, which is great, and I don't mean any disrespect to our K-12, our higher ed partners here, we forget that we really need to be working with students while we guide them, because that's where we expose them to the opportunities that exist in this profession, which is a great profession and we need people to go into. So I hope that's a part of the work of the group once they get going, looking at that.
Thank you.
Representative Jackson.
Thank you, Mr. Chairman. As I sat here, I wasn't going to say anything, but I always look at the people that are working in hospital, the aides and what have you, to see if there has been any kind of outreach to them. You know, sometimes you can see that one person that is so involved has that kind of encouragement been there for them. And again, when he mentioned the K through 12, but also those people that are out there that may not know what they really want to be, but they're the ones that are taking care of the patients. The other thing is, I know when we met once before, we talked about the nurses that are supervising these workers. How is there any kind of way that you've given thought to compensating them, as I know you can't pay them as teachers or what have you, but finding some way that you can pull all of that together. I have talked with some nurses' aides, and some of them would like to go to school, but they can't. They have not taken the test. There is a fear of taking tests, but to try and get someone just to work with the aides and to get them involved, but also as I listened, to see if we can get them into a program that they must give so much time back.
So we do have a lot of hospitals that are working on innovative ways to get additional education for those kind of entry-level clinical staff members through bridge programs and tuition reimbursement, et cetera. But I think to Representative Gamble's point, when you're intervening at the sophomore or junior level of high school and you can take advantage of a dual enrollment program, then you do kind of get them started out on the right foot. As we've surveyed our members, the number one response for what they're needing right now is not advanced practice registered nurses or PAs. They need bedside nurses. And often you see those come out of technical college programs. And so, yes, I think there's some opportunity there to incentivize, those nurses who act as preceptors and to potentially get, the educational institutions to maybe allow more of those part-time who are clinical right now into the teaching field so that they're getting that that extra kind of manpower behind educating these clinical staff members.
Representative McLeod.
Thank you, Mr. Chairman. Let me say for the record, COVID-19 is a virus that causes a disease. It does not care about our religious belief, the skin color, our gender, or anything else, and it does not read our U.S. Constitution. I just want to state that for the record.
Okay, I think we've exhausted all of our questions, Ms. Adams.
Thank you, sir.
Hold one second. Patty wants to speak. Yeah. You're good. Yeah. And now we're going to recognize Representative Bentley to speak to this bill.
Thank you, Mr. Chairman and members of the committee. I'll be very brief. We've heard some really good testimony from the healthcare experts, and I'm just here to share a little as your colleague and a caregiver for my husband. We all know the story of my husband being in the hospital for 6 long months last year down in Savannah. Started out at the hospital in Macon, Georgia, and for various reasons, and one being shortage of staff, ended up in Savannah Hospital. And so for 6 months, I drove from Atlanta to Savannah, back to Butler, from Atlanta to Savannah, back to Butler. And those months that I was there at Savannah Memorial Hospital, as well as Landmark, LTEC, I got a chance to see firsthand the need for medical personnel and the great labor shortage that we have in the healthcare arena. And so whatever this committee can do to help in this regard, especially with families that are in these hospitals seeing it firsthand, oftentimes I would help out. I would sweep up the floor and help take out the trash and help turn my husband, because he needed to be turned every 2 hours. I helped and pushed in and helped in those areas where they were lacking. So anything that this committee can do to help move this bill along, I want you to know that your colleague, who is a past caregiver, certainly appreciate your support. So, but I'm open for any questions if anyone have any, Mr. Chairman.
Representative Bentley, you do have a question from Representative Bruce.
Yes, sir. Thank you.
Yeah, I know the profession that you're in. I don't know if everybody else does, but is everybody on the planet knows.
I think we all know Representative Bruce.
Okay.
She makes it very clear.
Well, I'm looking around the room right now,
Uh-huh.
and me and maybe 2 other people have on masks. Nobody else has on a mask. Are you still burying people that have died from this virus?
Unfortunately, I am. Just recently, within the last 2 weeks, I have, as a matter of fact, a 52-year-old and a 26-year-old.
Were they vaccinated?
No, sir, they were not.
So the reality is that this virus is still causing deaths. Is that an accurate statement?
From my experience within this last 2 weeks, yes.
Okay. And part of that is because people are spreading it to each other. I have extra masks if anybody wants one, but I just wanted to find out if people were still dying from this.
Yes, sir. Yes, sir.
All right. Thank you, Representative Bentley. Here's what I'm going to do. I'm going to ask
Thank
the
you,
members.
Mr. Chairman and committee members and everyone in the audience for your
Representative. We
support.
have another representative going to speak. I'm going to ask all the members to do me a favor. This is not a forum to debate vaccines or viruses. We are here to discuss the measure before us, which deals with a crisis in staffing as it relates to a multitude of healthcare professions. Let's make sure that our questions are germane. We have another representative that wishes to speak. We're going to skip to her. Representative Davis, if you would come to the podium, the floor is yours.
Thank you, Chairman. I'm sitting here listening to everyone talk about workforce shortages, and especially about nursing. And am a nurse, over 25 years in critical care, which is one of the most critical areas. And I'm here saying that I can tell you straight off, I knew we were in trouble from the very beginning. A lot of times, it is our history that sets a foundation as to building a shortage. There's a number of people that don't understand that as nurses, a lot of times when you come out with new medications and so forth, there's a common practice among nurses and doctors not to do it for the first 2 years because they're documenting different side effects and that kind of thing. But the thing that really caught us off guard is the pay. I warned that there was going to be a run on nurses as far as the pay, especially your critical care nurses, because I was getting at least 10 or 20 offers talking about $10,000 a week. And I knew there was no way we were going to come close to being able to compete with that. Tell you the truth, I was tempted. I was saying, is there some way I can, lay off and not do my job? But then, of course, I'm an elected official. But who can turn away 10,000 plus a week? I mean, let's be real. And with the amount of money and with the pandemic, I mean, I had nurses when you did not have the PPE, that's the protective equipment. We've never seen anything like this before as nurses. And you have to remember, when we take care of you and you have an infectious disease, I run a chance of taking that back to my family. So when I don't have the right equipment, you can almost bet that that is exactly what I'm going to do. There are a lot of things we can do that is to build up our nursing staff. In the military, they paid for my nursing degree. For every year that they paid for, I gave them 2 years back. If here on the state level, in our colleges, we write an agreement, hey, for every year that we pay for your college, if you'll give us 2 years, and for some 3 or 4, that's a good exchange. And then they would give you a stipend. The military figured out an excellent way to build up their staff and also be able to train you in critical care, which is the ideal. If you have a critical care nurse, you can move them anywhere. Other nurses refuse to go to critical care, I'm sorry. And I'm a critical care nurse that will not go to neonatal. I take my hat off to neonatal nurses. But I'm saying, if you really want to know how to build your nursing force, you need to ask nurses. I understand, I see you have a number of people lined up from different organizations and all that, but I would ask for one meeting, just ask the nurses. Don't have no hospital, the kind of people that oversee them that they can get in trouble or have some retaliation. Have a set-aside meeting just for nurses to tell you the truth. Thank you.
Thank you, Representative. And to your point, this council would have not only nurses who are members, but representatives of statewide nursing organizations who would be members as well. So thank you for your comments. We're going to go next to Ms. Deb Bailey. Ms. Deb Bailey.
Thank you, Mr. Chairman, members of the committee. I'm Deb Bailey, and I represent the Northeast Georgia Health System. We're a 4-hospital system, not-for-profit in Northeast Georgia, and I am a registered nurse and have been since 1974, which tells you how old I am. But I think the most important part in that fact is that during my almost 50 years of being a nurse, we have seen lots of ups and downs. We've seen lots of times when we felt that we had a shortage of nurses, but never in that 50-year career have we ever seen anything like we have now. And yes, COVID exacerbated that in many ways, because nursing is a very difficult job, not because of what they have to do, but now, in addition to that, how they are also being treated, not by administration, but by our patients and their families. That's an additional huge issue. So I can tell you now we have over 10,000 employees in our system. We have 500 nurses that we are short. Before COVID, we would spend an average of maybe $500,000 to $1 million a month on agency staffing. We're averaging $12 to $14 million a month on agency staffing now, which is absolutely unsustainable. We have, over the last year, gone up on our actual cost of just running the business of a hospital on a daily basis. That cost has gone up over 30%. I think all the facts that have been made to this point demonstrate that there is no time like right now, that we need to study this issue, that it's a very complex one. There are no simple solutions. There's no easy or quick fixes. So we would really appreciate your support of this legislation and studying the effort of workforce shortages in the healthcare environment. Thank you very much.
Thank you, Ms. Bailey. You have one question, Representative Robichaux.
So I'm close to you. I have 45 years clinical experience. So but I can remember too when I started my career, you know, and yes, it's salary, it's that. We all started with the 8-hour shifts. And then, you know, when we moved to the 12-hour shifts, a lot of systems did it, because then you only had to technically work. You took 4 days, you got the 3 off. But I also think now, as technology and our expectations of what staff are expected to do, those 12 hours, and when we say 12 hours, I think people forget, you also have to give, those 12 hours do not often include your reporting times, that you have to take report, then you have to give report. So you're looking at 13, possibly 14-hour shifts that people are having, that are working. A lot of times we do it in 3 to 4 consecutive days. I think, you know, those of us in the legislature, as we sit, sometimes have to sit for a few extra hours. That might be something we all need to consider. I'm not saying we need to go backwards, but there might be something we need to look at there. Is there ways, because again, as I think another speaker said, you know, if the number of times my children came and had Christmas dinner with me in a hospital, you know, that's what we have to do. If you're a clinical staff, you take those. And even though I was in supervisory, I would let my staff off so they could. But so thinking along those lines of ways we could also make, it is the money, but it's the life we all want to live too.
Absolutely. Thank you. Thank you.
Real quick, these for-profit agencies, what are they offering out there to get these nurses straight out of school, or to take them from the hospital, put them under their jurisdiction to I guess contract back to you? What is there rules that you can't offer these nurses something that these for-profit agencies are offering?
Well, essentially, and we've always had agency staffing, and it's been very helpful in difficult times. But what we found over the last 2 years of COVID, the demand was so great because the patient load was so great. And there were times when in our system we would have 250 to 300 of our staff out with COVID. So that demand for those agency staff went so high. And with that it just became a bidding war for those folks. So many of my folks, understandably so, that had worked for Northeast Georgia Health System for a long time, they might have been making probably on average about $50 an hour. So the critical care nurse that was speaking just before me, at that point, we were paying the agency $200 an hour for a critical care nurse. So could we compete with that? No, not on any long-term basis. Because remember, hospitals, and most people think they go to the hospital, it's so very expensive, and it is, but hospitals are price takers. They're not price makers. We get paid what Medicaid wants to pay us. We get paid what Medicare will pay us. We do not tell them. And then the insurance companies, we contract for that, but those contracts are 2 or 3 years. And so here we are living through the last couple of years, and there's no way for us to compensate what we are spending at this point.
Representative Donahue.
Thank you, Chairman. And I just want to tell you, I always appreciate your open door policy. I really do. I mean that, because you probably hear from no one here as much as me. But I always
Probably, that's true.
But I gotta get an amen. But the biggest thing, I really want to acknowledge that, because you are always precious. You answer, we agree to disagree, and that's not often, but you come back with an answer, and I do appreciate that.
Thank you. Thank you very much.
Got it. Thank you for being here and appreciate all the information you've shared with us. I have a little bit of experience from my family. One's a CEO of Humana Hospital, has been for several years, and one's a doctor and one's a nurse practitioner. My wife retired from nursing. But my question is, now, what is the average salary or hourly pay that a nurse out of school who's just beginning, do you know what an LPN or an RN might be making at this present time?
Well, they're making probably on average about 20% or more, because most all of our nurses have had 3 to 4 raises over the last 2 years. And so I can't speak specifically for what a new graduate LPN would make, but I would think right now we're hiring new graduates at about $50 an hour for a registered nurse. Then remember, there are shift differentials in that, and now most hospitals are having sign-on bonuses. Most hospitals do have loan forgiveness programs. So we do have a lot of creative ideas and ideas that from the past that we're bringing back. But again, I think the efforts of this council, hopefully we're going to come up with some things we haven't been able to think of on our own.
And thank you. One if I may follow up. Do you know how we compare to the surrounding states?
It's interesting. Actually, in Florida, their nurses are making less than ours are. And then, of course, in other states, but it varies also across the state for the salaries. But I think, we're a pretty global society now, and we compete pretty well with most states. I mean, maybe not New York or California, but the states around us. You're welcome. Thank you.
Okay, thank you, Ms. Bailey. Now we're going to move on to Tom Bauer, and I'm going to ask, we have several lobbyists coming to speak. I'm going to ask that if everyone would, we want to hear from you, but please be succinct, and more importantly, ask our members to be succinct in their questioning. We've got 4 bills today. We're on the first one.
Thank you, Mr. Chairman. Tom Bauer with Leading Age Georgia, and we represent all kinds of senior service providers, including residential and waiver services, the whole gamut, mostly nonprofit and mission-driven. I appreciate very much Representative Hawkins, Chairman Hawkins, bringing this bill. We, of course, support it. I want to speak up for the long-term care industry, and and I hear folks talking, and it was interesting that Representative Bruce mentioned Burger King, because our biggest problem is being able to pay people enough and attract people, and frequently you hear the admonition that folks would rather go flip burgers. So I did approach Representative Hawkins because I looked at the language of the bill, and there wasn't really anything specifically about wage and rates and reimbursement rates, but he assures me that this is what it's all about, and I know Chairman Petrie will keep an eye on that as well. But we support the bill, and that's all I wanted to say.
Thank you. Julie? Yeah. Julie Wyndham.
Good afternoon, Mr. Chairman and members of the committee. My name is Julie Wyndham, and I am Vice President of Government Relations for Atrium Health. We have facilities in Rome and the Northwest Georgia area, as well as Macon and the Central Georgia area. But before I tell you about the impact that the shortage has had on those two communities, I'd like to point out in your packet of information, you have a letter from the Georgia Chamber. I actually have the honor of serving as the chair of the Health and Wellness Committee of the Government Affairs Council, and the business industry has decided that healthcare workforce is such a big priority for them that they have scorecarded this legislation and would like your support on that. But getting back to the hospitals and the impact we've seen from the shortage, not just through the pandemic, but starting before. At our hospitals in the Rome area, we have an average of 20% vacancy rate. At our hospitals in the Central Georgia area, that's a 28% vacancy rate. And that is despite our doing 3 pay raises throughout COVID. So we are raising our rates. We're just not finding the people to fill those vacancies. And what that means, unfortunately, is we are closing beds. At our medical center in Macon, which is a 637-bed hospital, we have on average right now, when we're not in a surge, 40 to 60 beds a day closed. Back during the surge in January, that range was from 90 to 120 beds a day that were closed due to staffing. At our hospital in Milledgeville, at Navicent Health Baldwin, we have a 140-bed hospital there, and average 25 beds a day closed at that rural hospital. So just to give you impact, I also have to admit we are the hospital that didn't have staff to take care of Representative Bentley's husband. We've worked with her on a lot of things. We were very sad that he had to go to Savannah to get the care he needed just because we didn't have the staff. So we would very much encourage you to support this legislation, and we thank the sponsor and the chairman for all the work they've done on it.
Thank you, Ms. Wyndham. Ms. Terry Hodges, who represents my hospital.
Thank you, Mr. Chairman. I'm going to be brief. I will say, because I'm Terry Hodges with St. Joseph's Candler Health System in Savannah, Georgia, and I know I don't want to go over any of this that's already been said today, but with 2 great members on this committee, the chair and Representative Jackson, I wanted to make sure that y'all knew that this is our #1 issue. When I report back home to what's going on with legislation, the first thing they want to know is what's going on with workforce. We certainly are appreciative of the things in the budget now and the things that we're trying to do, but we know that without putting this council together to pull all of these folks together, we're not going to, get to where we need to go. And I appreciate so much of the comments that have been made today with such great ideas, but that's just an example of why we need this council that's going to work on these issues going forward. So we thank the committee for their consideration of passage.
Thank you, Terry. Josh Mackey.
Thank you, Chairman. Josh Mackey, I represent the Georgia EMS Association, statewide association for EMTs, paramedics, ambulance services across the state. Want to start off saying, we're supportive of the bill, supportive of the effort. I think it's a great construct of the council to bring apart education, healthcare workforce. We would like to see EMS be a participant. We'd like representation on there or a designated subcommittee. EMS has had massive workforce problems across the state, urban and rural, predating the pandemic. The pandemic has only exacerbated that. And given we're kind of at the bottom of the chain pre-hospital care, oftentimes EMS is a launching pad for nurses and PAs and physicians. And so if we're having workforce issues, the workforce issues are only going to be worse, further down the line and when you get up to the hospital and other medical care. So we're supportive of the effort, like to see it move forward, but either here or later in the process, just want to be on record, we'd like to see EMS directly represented. Thank you.
Thank you, sir. Okay, is there anyone else that wants to speak on this bill? We have seemed to. All right, Tim. Oh yeah, did we miss Tim? Did we miss you, Tim?
Well, I'm easy to miss.
No, we had you. Tim, the problem is you signed up to speak on every bill we have today, and I think we got confused. We thought you were speaking on another matter. The floor is yours, my friend.
Mr. Chairman, I am Tim Kibler with the Georgia Alliance Community Hospitals, and in the interest of time and the committee's time, I'll not repeat what my colleagues have just said, but we very much commend this bill to you and would ask for your support for it. This is probably the most important thing the legislature can do to help meet the future health needs of Georgia residents. I'll be glad to take any questions if there are any, Mr. Chairman.
All right, Mr. Kibler, there are no questions. I think we've fully exhausted all the testimony and questions.
Make a motion.
Representative Hood, it is the proper time.
Make a motion to pass.
Do we hear a second?
Mr. Chairman.
Yes, Representative.
At the appropriate time, I'd like to make a friendly amendment. I know the author
Okay.
had to step out, but
We're
at the
almost
appropriate
there.
time.
Almost there. Gotcha. All right. So we have a motion do pass. We have a second. And that is for the substitute bill. Now, everyone has before you, I don't recall Chairman Hawkins reading that number. Let's be very clear. Let me make sure I'm clear, because I've marked up both versions. So let's go to, not this one, this one. All right, everyone should have before you, let's be real clear on this. LC 339091S. Is that what everyone has? Okay, because there were some changes made this morning. And, all right, so we have a motion to pass the substitute House Bill 1520 LC 339091S. We have a second. All right. Is there any discussion? I know we got some coming down there, but we'll hold on that. Any other discussion on this matter? Any members desired to ask any further questions? All right. I see one. Representative McLeod.
I don't have any thing. I just wanted to say during our special session, this was already on our table and on the alert. And so I'm glad that we're moving forward with this piece of legislation, because whatever we can do to help our frontline workers and just making sure that we can train up folks right. And this morning I was really happy to see some young people that are stepping up to this position out on Liberty Plaza. So I'm in full support. I don't know what my colleague is going to add, but I am in full support of this legislation.
Thank you, Representative McLeod, and I will echo that. Our hearings we had during the special session, and there's a multitude of areas where this issue we've helped to make it prominent with this committee, and that we should all be proud of that. All right, it is the appropriate time then. He represented my seatmate, Representative Allen down there. Has an amendment.
Yeah, thank you, Mr. Chairman. I kind of piggybacking on what Representative Bruce was talking about, being someone who has also worked as an administrator in healthcare and specifically HR, I would like to see either at line 40 or 51, where there's a representative from a hospital or health system, that it be specifically called out that is an HR professional, a human resources. I think that is a missing piece on this committee to really help guide some of that conversation.
Okay. I would ask you to, let's discuss it now. While we do so, if you will precisely make the change in writing you would like to make a motion as an amendment, and let's discuss it. All right. Member comments regarding this amendment, or this proposed amendment? Conversation? Give everybody time to look at it. Yeah, Representative Gamble, are you 16? Okay, yeah. Representative Gamble.
I guess I would just ask, I mean, you get to a point where if you had so many people, who's going to be in the audience to speak? That would be my only question, because I don't disagree with you that HR would be good and Josh's EMS folks, but I mean, wouldn't it be allowable to have them as a presenter rather than having to actually serve?
Say that again.
Wouldn't it be allowable for them to present rather than to actually have to be named in the legislation?
Personally, I think we should allow the hospitals to decide who they think could best represent them. But would the hospitals like to speak to this issue? Would a couple of you like to speak to that as we discuss it here? We got another question. That is, Representative Bonner has a question. One of y'all, the hospitals, even collectively, y'all can make your way to the front. We're glad to hear from you.
Well,
it's okay.
Well, hey, Mr. Chairman, mine was just simply a comment on the motion. I would propose we leave it as is. I would echo your comment that the hospitals ought to choose who they think is best, and it doesn't preclude them from putting someone on or recommending someone who has HR experience. But I would recommend we not limit that just to that.
Okay. Thank you. I tend to agree with you, but I just want to make sure everybody gets heard. And my friend here, I know, has absolutely the best intentions. Any other comments from the committee, and then we'll go to Ms. Adams. Okay. All right, Ms. Adams.
Thank you, Representative Allen. I hear your point. What I will say is that as the workforce challenges have been exacerbated during COVID, many hospitals have working committees to deal with this challenge, and while they may involve HR, it is not HR exclusively. And so I think maybe having the hospitals have the ability to appoint that designated staff person who's very much in the know on what their relationships look like in the community might be a better option.
Okay.
yeah.
Thank you.
Mr. Chairman,
Okay.
I'll withdraw.
Okay, that's how I was just fixing to ask you if you would like to pursue it or withdraw. Okay, so we will not pursue an amendment to the current substitute. All right. Is there any further discussion? All right. We have a motion and a second. All in favor? Aye. Any opposed? All right. This measure has passed unanimously. Is Chairman Hawkins still in the room? No. He's got too many bills. Yeah. He thought this was a 5-minute bill. All right. All right, Representative LaHood is up next. Wherever you choose,
I'll stay here.
Chairman, if you want to do it here. All right, let me just mention. Let me just find it real quick. To all the members in. All right, so Representative LaHood is going to bring us a substitute to House Bill 1531, that is LC 339089S. Please check that. It was changed today as well. Okay. Chairman?
All right. Thank you, Mr. Chairman, and thank you, Representative Allen, for letting me sit in my chair to present. Appreciate that. I'm glad the House Bill 1520 we just debated, I'm glad it went before this one because it made a lot of my points that I need to make in this bill. This bill involves the senior care settings, specifically assisted living communities and personal care homes that have 25 or more beds. If you remember, a couple of years ago, there was some pretty major legislation that transformed a lot of the way this industry is regulated, and those new rules and regulations have been in place now for since I believe it was last October. The department's here and can clarify if needed, but a lot of what I heard in the last debating the last bill were things like beds are closing because there's just not enough staff, or the business model's not working. There's 28,000 nurse positions open that are unfilled. Some members of this committee said turnover is expensive, burnout is high. Chairman Hawkins, his opening remarks said that the healthcare workforce has been decimated. I agree with all those comments. And so what my bill does, it puts a couple of practical measures in place to help alleviate some of the staffing challenges while not compromising standards of care. And so two things, I'll hit the highlights. The first thing it does is bring the licensed nursing hours to an average monthly minimum. Current law states average weekly minimum. This bill would change it to an average monthly minimum, which brings it in line with the direct care staffing requirement, average monthly minimum. What this would do would give providers and nurses who work for the providers and care for senior adult residents the flexibility to adjust their schedules, but all while requiring that the total hours in the month meet the current requirement. They just might be lighter one week and heavier the next week. So with a shortage of 28,000 nurses, this would just give some flexibility to the schedule that the nurse works, all while making sure that the standards of care are not compromised. And the next thing the bill does is make sure that the staffing ratios that were stated in House Bill 987 a couple of years ago is what's actually happening in real life in the buildings. And so we're just putting some clarifying language in here that says that as long as the staffing ratios are met, and those are currently in the assisted living or personal care sections or non-memory care sections of the facility, the minimum ratio is 1 to 15 during waking hours and 1 to 20 during non-waking hours. And the language in this bill just clarifies and makes sure that that's what can actually happen. The way the current rules read, actually in certain scenarios would require a stricter staffing ratio in an assisted living setting than what's required in a skilled nursing setting. And so this bill, this language in this bill would bring the ratios in line with what was intended. All right, and we did the same thing for the memory care section. The current ratio is 1 to 12 during waking hours and 1 to 15 during non-waking hours. And the clarifying language in the bill does just that. It clarifies that that's what can be practiced in the facility. So I'm open to questions, if there are any. I believe we have a few people that want to present.
Okay, let's take questions for the sponsor first, and then we'll have any others. We do have a good number of people lined up to speak. Okay, first we have Representative Mitchell.
Thank you. I just, I'm trying to wrap my head around what an average monthly minimum of 8 hours translates into in real life. So a minimum of 8 hours per week, I understand very well. An average monthly of 8 hours per week, I understand very well. What does an average monthly minimum of 8 hours per week mean?
Okay, thank you for the question. And what it means is, so an average minimum of 8 hours a week means there needs to be at least 32 hours in a 4-week month. And the language in the bill would ensure that those hours can be spread based on resident need in the building, number one, based on availability of a nurse to meet that need, and based on, it just allows fluidity. And, 8 hours is the minimum, and that's for the smallest number of residents. Then it moves to 16 and goes all the way up to 40 hours a week. And so let's take the 16 hours a week, for example. There might be a week where the nurse is present 8 hours in week one of the month, and then the second week of the month they're there 24 hours. And so by week 2 they've met the average for the first half of the month. And then the next 2 weeks, could go the same way, or the nurse could be there 16 hours, for each of the next 2 weeks, if that makes sense.
I think that you just mean an average. Correct?
Yes.
So maybe we don't need the minimum, because I think that language is fairly confusing.
I have been meeting with the department about it, and what the language in the current statute says is average weekly minimum. And so this is just replacing the word weekly with monthly.
Well, in the current statute, it says a minimum of 8 hours per week. There's no average in that. If I'm
Oh,
looking
I
at the
got you.
original.
Okay.
Yeah. So I think we probably need one or the other, and then it's a more clear thing, because an average monthly minimum per week to me would mean you'd look over the course of months to see what the minimum per week was within a month. So it ends up mathematically confusing.
Well, we've got average monthly minimum is used in other parts of the current statute for direct caregivers, and so we were just mirroring that language. The department's here. I'm not sure if they wish to speak to that or not.
Okay, let's let the department reflect on that as we go to, y'all reflect on that as we go to Representative Robichaux for a question.
So in that, I just want to also make sure, the way I read this, and I think appropriate, the differentiation with the memory care units is that, number one, you do have to have a dementia-trained direct care staff person for every 12, 15, 100%. B, it says a registered professional nurse, licensed practical nurse, or certified medication aide on site at all times. And then C is where we're mimicking the assisted living concept, and also in the respect to the additional registered professional nurse or LPN with those hours per week. So I think we need to make sure people see that there's a differentiation. In a memory care unit, you would still have minimum, it sounds like at least 3 staff people there at different levels.
Okay, I see where it could give that perception, but no, the minimum would be 1 staff person that could be on site in a memory care center, and but that 1 person would have to be either a licensed nurse, licensed registered nurse, licensed practical nurse, or a certified medication aide. They would have to hold one of those credentials.
Okay, so line 39 through 42, it states that a memory care center shall meet the following minimum staffing requirements. 1, dementia-trained direct care staff person for every 12 residents on site during all waking hours, or for every 15 hours. Then B, so that's one thing you have to meet. Then you have to meet 1 registered practical nurse, LPN, or certified medication tech. That's 2. And then C is 2 direct staff persons, except depending on staff.
Right.
Am I
So-
misreading that?
So what that means is whether it's a licensed nurse or a certified medication aide, they would need to meet the minimum training requirements.
I understand that's
It's-
part B. I'm going back up to the 1A, the dementia-trained direct care.
Mm-hmm.
What's the difference? Why, maybe why would that, if you're saying that falls under the same thing in the grouping of registered nurse, practical nurse, or medication aide, should it not?
They could be one and the same. The registered nurse, the licensed practical nurse, or the certified medication aide would also meet the requirements in A.
Okay.
1 dementia-trained direct care staff person for every 12.
We might want to make sure that because that to me was not clear.
Right. Well, that's how it is in current statute. I get where the confusion might be coming in.
Well, no, I read it that you have to have a minimum. You have to have a minimum of A, B, and C. Versus you're saying I have to have a minimum of A, B, which is together. And then, so maybe I'm just.
Right. Well, this is how it was. This is the language that was passed a couple years ago, and it went through tremendous vetting and debate. Good point. Yeah, I agree. Maybe it could be improved, but
We're going to, let's go to Representative Allen for some clarification, and then we're going to come to Deputy Commissioner Hood to help us here. Representative Allen.
Yeah, and I think what Representative Robichaux is saying is true, and it could be cleaned up a little bit just here before we vote on it. But it does read that it needs to be one of A, B, C, and on line 48, it even uses the word and D. So it reads like you're saying it needs, so maybe there needs to be some language clarifying at the top that says one of the following instead of saying the following. If that's your intent. I'm just trying to help clean it up a little bit, because
Right.
the word, the operator and really encompasses all four.
We certainly like clarity, so I appreciate the comments for sure. On line 48, where you mentioned the "and," that's going to the licensed nurse that's not going to be there all the 24 hours a day, but be there, a certain number of hours a week or a month.
To clean it up and take out the ambiguity, I think it would be wise to clean that up just a little bit so it's not as, otherwise it could be strongly interpreted that you're saying 4 different classifications. So I think it's a friendly conversation.
No, I understand. No, and I take it as friendly. I appreciate it, and I know the department worked really hard on, promulgating rules and regulations to go along with House Bill 987 a couple years ago, and
Let's go to Deputy Commissioner Hood there. Let's see get his advice.
Good afternoon, Mr. Chairman. So I think the first question was in regards to the monthly average versus weekly, right? So, we would probably prefer that we still maintain the weekly average. And the reason this would be different than whereas in other places in the statute is those are full-time staff when you're talking about ratios there, and when you're talking about nursing services here, we're talking about an average number of hours. The reason we would want to keep the per week is what is operationally going to happen is if we have a complaint and we go out and we investigate a complaint and we verify that there is a lack of care for an individual patient and it's due to a lack of nursing care, we're going to want to rely back on a corrective action plan that points to that per week. It blurs the line, a little bit if you say, well, you rely upon that on monthly average. Now, we can do that in administrative rule. It's not a break. If you go to monthly average, we're still going to go on direct care, and then we're going to say, this is how many staff you need. And you got to remember, this is a minimum. This is a minimum monthly average. So if your memory care unit is full of high acuity patients, then when we go out, we're going to say that you need a lot more staff than this because look how many patients you have, and your patient care plan says you need, reflects that you need X number of staff. So, I don't, either way you guys want to go, I think it's helpful to the department to be able to point back and say, the intent originally was 8 hours. You can have a monthly average as long as you don't have any complaints that are, that are related to that on nursing. That would be my suggestion, but it's operationally, it's not going to matter whether you say monthly overall or stick with the weekly. I think it's helpful for weekly for a reference so we can point to that and say that was the original intent.
Yeah. So thank you for those remarks. So the going to the monthly average will, like I said, give flexibility in light of the massive nursing shortage. Where it might be impossible some weeks to have a nurse on week 1 of the month, and then the provider is out of compliance
for
that
other
whole
example
month.
that I had, I'm sorry.
No, go ahead.
The other example I had, Mr. Chairman, was that if you have a high acuity of patients or number of patient census in one part of the month or one day, I'm fairly confident on weekends versus weekdays, depending upon how many are out for other care. Or if you happen to have some that are in the hospital and it fluctuates your census within a single month, that would give you the possibility to have your highest nursing staff when you have your highest census.
Exactly.
And I think that's the best argument for why you want to do this is because otherwise we're saying you've got to have a minimum every single day. But what if your census is really low on the beginning of the month but really high on the end of the month with part-time nursing, which is what this is specifically addressing? I think that's the best reasoning why you would want an average to allow, as you would put it, the flexibility to put the nurses when you have the most need for the patient care.
That's right.
So that's...
Yes, and the provisions in here for example, on line 19, it says, however, that either such ratio is adequate to meet the needs of the residents. And that's the overriding or the underpinning of all of these staffing ratios.
Right.
What we're talking about is minimum staffing ratios in instances where resident acuity is low. In other words, the residents are high functioning, the resident mix, or census is low, or different scenarios. And this just gives providers that opportunity to staff to the need and not to a rule that's needlessly raising the costs and making it harder to comply.
Thank you, Mr. Hood. Are there any other questions first from the body for Mr. Hood at the podium? I have some that were already flashing, but are there any for Mr. Okay. All right. Thank you, sir. Thank you very much. All right. Recognize Representative McLeod.
I guess I kind of was trying to understand. I understand that trying to get the flexibility, but logistically, how are you guys working out the like? We know there's a shortage of workers, plus having the flexibility. Is there like, do you have like a pipeline of folks ready to go? Because if you're saying an average of 32 hours, then that means there's some gaps in between. Do you have enough manpower or nurses to fill that gap based on this bill? I was a little confused about how logistically that works.
Right. If I understand your question right, I think the answer is no. We don't always have the manpower. There's a shortage. We're competing for the same nurses that the hospitals that just spoke are competing for, and also please bear in mind the facilities that I'm speaking about are private pay. The customers are private pay. They write a check for the services they receive. There's no government funding source, no outside funding source. It's all private pay. So they're choosing where to spend their money, and if they don't think the care is adequate, then them or their families will go somewhere where it is.
Yeah, the struggle is real.
It is a real struggle.
Representative Mitchell.
Thanks. So I realized I could explain myself better. What you have now is written average monthly minimum. I think minimum monthly average is what you mean. Is that the correct interpretation? Because they're different. One is a totally different thing than the other, even though they're the same three words. But I think what you mean is a minimum monthly average. Just.
That could read a little bit easier.
Yeah, and it
Minimum
means
monthly
something.
average.
It means something else. Yeah.
I wonder if
The challenges is in other code sections, correct? I'm waiting to hear from them. Could the department come speak to this again? I hate to keep jerking y'all back and forth like a yo-yo, but the language is real important that we know what we're discussing today. It is sometimes cumbersome language, and let's get this right. Mr. Hood, thank you.
I think that's accurate. I think you want an average minimum monthly, not like 2 months. Like we're not taking 2 months together. So I think that's accurate. That this reads, that could be interpreted perhaps that we were talking about over several months. So I think it's just a reversal there, as has been suggested, an average minimum monthly.
that's right, and that was the intent. So appreciate the help clarifying that.
I think I would almost do minimum monthly average even, right? Because then it's clearer that you're looking at a monthly average and you want the minimum of that.
Yeah.
So minimum monthly average sounds good to me.
Okay.
Yeah. No.
No, it's not.
We'll just need to apply that in several places.
Yes.
I believe there's 8 different lines that would need to go on.
And that's in the existing statute, correct? That's the language in the existing statute as it relates to staffing ratios, et cetera.
It is that we were replicating.
So
yeah,
if
that's
we
not
could-
how we're interpreting it. just so you know.
Right. No. Well, we know y'all are interpreting that
Right.
way. But this, if indeed this can make it better, then,
Right.
Okay. We have Legislative Council making notes. Are there any other questions in this matter? Okay. Thank you again, Mr. Hood, and Miss Brandy back there. Y'all are the best. Y'all are the absolute best. All right. Now we're going to hear from some others. Let's do that as we let Chairman LaHood and Legislative Council work on some of those recommended changes. Let's hear from Mary Lee Boatwright. Quinn. The floor is yours, my friend.
Thank you, Chairman Petrie and members of the committee. And I just want to thank Representative LaHood for not proposing any changes to the training, because that was a very important piece of HB 987. So thank you. I'm from the Alzheimer's Association Georgia chapter, so representing those folks living in assisted living and memory care. Some of you may not know that most people place their loved one into assisted living first because they may not need quite yet memory care. So 42% of people living in that assisted living side have dementia. And then you would assume that 100% or close to 100% in the memory care units have dementia. So our greatest concern here is that the needs of residents will not be met with the changes in this sub on lines 45 through 48, reducing that direct care worker requirement to 1 if the census goes less than 12 during waking hours. This is memory care I'm talking about. Less than 12 during waking hours and less than 15 during non-waking hours. Unfortunately, people with dementia don't follow the rules of waking hours and non-waking hours like we do. You know, you go to bed at a typical time every night. That's not how it works with dementia. And in fact, most families that keep their loved one at home, it's those waking hours at night that's the exact reason that they place their loved one into assisted living. That is the number one reason, because they can no longer wake up, and they're 1-to-1 care, and sometimes 3-to-1. Sometimes it takes 3 family members. They're waking at night, and then that becomes difficult for them to function throughout the day, right? So imagine if at midnight in one of these facilities that now has 14 people in memory care, so it's under that 15 minimum, you've got 1 direct care worker on that floor, and you've got somebody who needed some personal care in a room, and now that direct care worker just went behind a closed door for, let's just say 30 minutes. It could be longer than 30 minutes. And for that period of time, the remaining 13 people don't have anybody. So we realize that the rule, the way it's written, is homes should not, if they have folks, 12 out of 14 of those people are wandering, they shouldn't be going down to that one person because of that acuity level, and they will be, surveyed for that. But unfortunately, there are providers who are going to take these as the standard, and they're going to go with this, and I met that minimum, and they're going to argue to the hilt that the acuity level was not higher. They didn't know it was higher, so they didn't need to be staffing it higher. So I would argue that, the provisions for this overnight care was actually one of the main focuses that Chairman Cooper had on HB 987, because a lot of those stories that we saw in the AJC investigative series, unfortunately, they happened overnight when staffing levels were low. So I would just have asked the committee members to please take that into consideration, because I do think that this changes the standards of care and it compromises standards of care. And unfortunately, the needs of people with dementia, they haven't changed since the governor signed this bill in July of 2020. The needs haven't changed. It's the healthcare workforce that's changed. And so I don't think that we should legislate and change care standards based on workforce issues. Love Representative Lee Hawkins' bill. All of our aging advocates want to help with workforce shortage issues across all settings where older adults are being served. And so let's put, effort, budget money, so forth into that rather than reducing care standards. And I'll yield for any questions.
Thank you very much for your remarks, and I've always enjoyed working with you on legislation for seniors, and I think you know that I'm an advocate, like you are, for seniors' best interest. I've sponsored bills to protect seniors. I see the Prosecuting Attorneys Council back there. I've sponsored bills for them to protect seniors, and that is what my heart and my interest are. You made good points. However, there are scenarios where you've got a memory care center with a high acuity, high functioning residents who do not require one-on-one attention. The only way to, the best way to make sure no negative incidents happen is to have one-on-one care. And most people can't afford one-on-one care, even with 2 staff for 12 residents. You can't guarantee there's not going to be a negative incident. You would have to have one-on-one, and then I've seen situations where a resident has a one-on-one trained sitter, and the resident still falls and gets hurt. So there's really no way to guarantee that there will never be a negative incident. But the way the current rules and regs are written, there are certain scenarios where the staffing requirements in a memory care center and an assisted living or personal care environment are stricter than they are in a skilled nursing home. I mean, that's fact. For example, if an assisted living, a memory care center had 6 residents, the way the law and the rules are currently written, you'd be required, the provider would be required to have 2 caregivers for 6. Or if there was 1 resident, the provider would still be required to have 2 caregivers for a resident. There's language here that underpins the staffing requirement that says, however, that either such ratio is adequate to meet the needs of the residents. So what we're talking about is minimum. You go up from there. And so I appreciate, your concerns and your comments. I really do, and I understand them. Yeah. But what we're talking about is a minimum requirement, and you go up from there. You just don't go below that minimum. So if the resident needs are greater, then the staff is greater. And the surveyors, the department will survey to that standard.
Representative Bruce.
Yeah, we often talk about this in relationship to elderly. Is there any evidence showing that the age factor is reducing? People younger are having these same issues now?
Well, there are younger onset dementias, if that's what you're asking, and there's prevalence increase across all dementia. I don't know the percentage, but your risk level goes way up the older you get, though. The number goes up, over 65, and then over 80 is even way significantly higher. But there are younger onset. I have a neighbor whose husband was in memory care at 56 years old with a younger
I'm just trying to see if there's going to be competing, are we going to have a situation where we already don't have enough care? Is it going to get worse because the age limit is reducing also? That's what I was trying to get at.
Yeah. I don't know that it has to do with the age, but the prevalence of dementia is increasing 26% just in our state by 2025. So,
is there something that people are doing or being exposed to that is causing that increase?
I can give you a lot of the evidence that's come out. There's a lot of around prevention, but no causation is really not known yet.
Okay, and having spent my entire career in the world of caring for seniors, I think it's that we're living longer. I think we all can agree that has a lot to do with it. We continue to live longer and certainly see increases in Alzheimer's and related dementias. All right, we're going to go to a question here from Representative Mitchell. Hang on, Ms. Boatwright.
Yes, thank you. I really did appreciate your coming to speak to us about the staffing ratio. And I am curious if there is a threshold below which that one direct care staff person would be, in your mind, an appropriate number. Between 1 to 1 and 1 to 12.
In all transparency, Representative LaHood asked me the same question. And unfortunately, we don't have, a a staffing level requirement that we're going to, because it really is about acuity. But I think 15 at night with one is a lot. And that's why we made it 2 in the original language of the bill in 987. And then, you know, on the assisted living side, that's 20 to 1. So again, if that one person has to go deal with a rather long-term crisis with a patient, it's difficult that you don't, and then you don't have other eyes. You know, you don't even know necessarily, I mean, yes, there's other people in the building, but you don't have other eyes on that direct care worker to kind of hold them accountable that they're not sleeping at a desk or some of those things that we heard in the articles, which I'm not speaking to Representative LaHood's facilities here. We're talking about, you know, the bad actors in this.
Yep. Well, one of the main reasons that makes an assisted living or personal care home setting attractive to seniors is the fact that most people can't afford one-on-one care, or we know that there's over 300,000 unpaid family caregivers, you know, in this state that are providing care. So most people cannot afford to pay a one-on-one caregiver, and so that's what makes an assisted living or personal care setting attractive. They can essentially split the cost of a caregiver between multiple residents. So the lower you get that ratio, the more expensive the care gets. And what we're going to do, if we confine it, like the current regs do, you're just pricing it, getting it, you know, out of range of what a lot of consumers can afford. And so all this bill is doing is giving flexibility so that residents who do not need the extra attention of a one-on-one or 1-to-2 or 1-to-3 or 1-to-6 ratio don't have to pay for that level. And so we put 1-to-12 in the statute a couple of years ago in 987, but the way the department has interpreted it and the way it's in rule, it's pointless to have a 1-to-12 ratio if you have to have 2 caregivers.
All right, thank you, Ms. Boatright. Let's go to Mr. Kibler. We're going to we hear all the testimony. Mr. Kibler, you're good with this one? See, I didn't want to miss you again. Went to you first. All right, Ms. Debra Stokes. Oh, then Tom Bauer is on deck.
Thank you, Mr. Chairman and committee members. I am Debra Stokes, Executive Director of the Georgia Council on Aging, and the co-age membership, our 1,200 plus members of the Coalition of Advocates for Georgia's Elderly. And we were concerned about this bill and how it would weaken the delivery of patient-centered care that the legislature and the governor put in place back in 2020 with House Bill 987. The changes in the bill have been admirable, but we were a little bit concerned that it would make all of that hard work for 987 kind of go by the wayside. So that's why we're here to speak to it. We're also a little bit disappointed that we weren't involved in the development of the bill, nor were our coalition of advocates weren't aware of this bill coming forward. And, you know, Representative LaHood has been such a strong advocate, and we just wanted to make sure that that this new bill doesn't weaken to a dangerous extent 987. And we are very much aware of the need for workforce improvement, and honestly, Representative Hawkins' bill is the thing that needs to happen, as opposed to legislation that would take away from patient-centered care. Let's have legislation that would improve the workforce so that patient-centered care can be the focus of what we're doing, as opposed to regs that change that. We're basically very much concerned about the welfare and the well-being of our aging population, and we're just interested in making sure that the new laws don't weaken the old ones. That's it.
Thank you so much.
Thank you.
Mr. Bauer. And Mr. Skin Edge is on deck.
Thank you, Mr. Chairman. I feel like rather than being on deck, I should have a pinch hitter because I had to step out and talk to a senator. I had a meeting scheduled, so I have not seen the substitute. But I did want to say it was in our understanding that this bill is not intended to weaken, but to give the flexibility that Representative LaHood had mentioned, and I don't want to strongly disagree with the previous speaker, but when the department did come out with the rules, and I'm very proud of our providers at Leading Age, and I'm very proud of Terry Barcroft, who is our incoming president, who's the CEO at Wesley Woods, and she had the same reaction when the rules came out, that they were actually a little bit beyond what 987 did. The instance I remember was the one that somebody on the floor at all times, even when your whole population was up eating or something. So we are in favor of the concept of this giving the flexibility, because we really do have a shortage, and if we could have a little flexibility, it would be helpful. And I'm sorry I can't be more specific because I have not really seen the substitute.
Thank you, sir. Mr. Edge.
Mr. Chairman, thank you. Members of the committee, thank you for allowing me to come before you today. I represent the Georgia Senior Living Association. The Senior Living Association is comprised of both assisted living communities and personal care homes, most of whom have 25 beds or more. In Georgia, that translates into about roughly 450 communities with about 33,000 beds spread all across the state. We worked very closely 2 years ago with House Bill 987. We supported the concepts in 987, and we were proud to support that bill all the way through the legislature, working with Chairman Cooper and others. We support this bill brought by Representative LaHood here today. We do not think that it weakens 987. Rather, it does a couple of things. Number one, the word flexibility has been used. All of you heard the testimony on the first bill today and the staffing shortages we are facing. That has become acute not only in hospitals but in assisted living communities and personal care homes. All too often we train nurses in our facilities only to see them leave us and go to hospitals. So it's really, really tough on us. So we've got to have more flexibility. We think the measure brought by Representative LaHood frankly does what 987 was intended to do. I would stress to the members of the committee, again, these are minimum standards, minimums. When the department surveys, if they find that our patient load is such that we need more caregivers and we're not doing that, we can be cited on that. We can be fined on that. These are minimum standards, and I think you need to keep that in mind. That's very, very important. So flexibility and minimum standards are the two keys. The other thing, as Representative LaHood said, we are fighting desperately to try to keep our services affordable to the average Georgian. We're not paid by Medicare like the nursing homes. This comes out of our patients and their families' pockets. And any time that the staffing ratios are over what they are needed to be, that adds costs that we've got to pass on. And with the issues we've had with the pandemic and others, our members are facing intense financial strains that we're trying to overcome. We think this bill will help us do that, and at the same time provide the care and the services that our older citizens deserve. So I would appreciate your support of the bill. Be glad to answer any questions.
Thank you, Mr. Edge. There are no questions. Here's the posture we're in, and do want to thank you for your comments. I want to say this, having worked with Chairman LaHood on the current statute, I know well, you were the second signer on that bill, as I recall, so I know well your commitment to making sure that we focus first and foremost on quality care. I think we all recognize we got some real challenges here with staff shortages. We understand the need for flexibility for some of these positions that are not 24-hour, but I feel like we're not quite there, and so we're going to hold on this measure. We're not going to vote on this bill today. This has been a good hearing, but I think I'm going to ask the sponsor to work with the department and with any other interested parties to help us to tweak it to where it's just right, so we're all confident and comfortable. And rather than vote today, we do we have a comment from, well, Terry Rogers? Come on to the podium, if you will. So I think y'all know where we are with this, but let's hear, it looks like I forgot another one. I'm sorry, Terry. How quickly we forget our old colleagues.
Look, I'm gonna do this. I'm gonna do this real fast because believe me, it's a little bit strange to be on this side.
I didn't recognize you without a badge on.
But Mr. Chairman, I appreciate the opportunity to come. I'm Terry Rogers, represent the Georgia Trial Lawyers Association, and I really feel like I ought to just say ditto because what I'm hearing right here is a lot of concern about the possibility that this might have weakened some of the things. But I appreciate the opportunity that Chairman LaHood and Chairman Petrie, you both talked with me offline about this. We just want to make certain that what we have with 987 is not weakened. And I know that you guys are looking at that. That's why you've taken this posture right now. And would appreciate you're making certain that our seniors get the care that they need. Appreciate it. Thank you.
Thank you, sir. All right, so I think we all know where we stand there. And now we're going to take the last bill of the day. And it's on page 2, and that is Representative Smith. And I was looking at HB 1436, Representative Smith. Yeah, 1436. Now we have a substitute, correct, Mr. Representative Smith? Let's make sure we.
Yes, Mr.
If
Chairman.
you'll read us that new LC number, let's make sure everybody has that.
Absolutely. Thank you, Mr. Chairman. LC number 339073S. First, I want to say
Yes.
thank you, Mr. Chairman. Are you guys ready?
Yeah, yes, sir. Go ahead. I think, does everyone have the correct LC? Okay, thank you, sir.
Okay.
Representative Smith?
Thank you, Mr. Chairman, members of the committee. Before I start, I also want to give a special thank you to Representative LaHood for his work on this measure, and also Sheila from the Georgia Healthcare Association as well, if she's still here. She's here in spirit. All right. Today I bring before you HB 1436. This bill simply adds an additional requirement of our long-term care facilities to post the state ombudsman information on their website. Currently, the state of Georgia requires the contact information for the Ombudsman Program to be posted in visible areas throughout our state's long-term care facilities, but it does not require them to post it online. By updating and modernizing our existing requirements, this will allow family members, legal guardians, the opportunity to access this information remotely and make them aware of the Ombudsman Program that is already available to them. And should there be a similar event like the current COVID-19 pandemic, where family members and other visitors were not allowed in the facilities, this bill seeks to inform all residents and family members of the Ombudsman Program, regardless of their location and their accessibility to the facility. Also, there is no requirement to create a website, and there is no or very limited cost to this bill. The state of Texas already requires this information to be placed on their long-term care facility websites, and I have an example of this information that could be displayed on our websites here in Georgia as well, and you guys should have that at your desk. The first page of the example is the home screen, and the second one is where they would have the link. Very simple, what we're asking for today, and this information is vital, critical, I guess, to the care of our aging adults. With that being said, Mr. Chairman, I would yield for any questions if there are. If there aren't any,
Okay.
I ask for your
Representative Smith, I
consideration.
think we'll have, this one, I think is going to be an easier bill to deal with. I will tell you that.
Sounds good.
I will tell you that, so the Ombudsman Program, a great program in this state, and of course in all long-term care facilities, those posters have to be prominently displayed already in statute. I think that when I first read this, I felt like it was a very good idea. If you have a website, and it was important that you worded it that way, but if they have a website, I think it's easy to attach a link, and this can be very helpful. But we will take any questions. We'll begin with Chairman LaHood.
Thank you, Representative Smith, for bringing this bill. And this is more of a comment, not a question, but I've enjoyed working with you on this. And I'll just say I think this is going to help consumers, residents of long-term care settings to know who to call if they do have an issue, a concern, a complaint. I was speaking with the department this morning, and since I've become elected to public office, a lot of the public associates me with kind of an expert on senior care, and so I get a lot of calls, inquiries from people all around the state that ask me, what do I do about this, unsafe condition that my family member's in, or who do I call? Well, this will make it a lot easier to direct people to who to call, and probably cut down on a lot of calling around to figure out where they need to go to file a complaint, essentially. So. A lot of providers have websites. A lot of regional providers or providers that operate in multiple states might have one website with different pages on the website for their different locations. And so would you consider a prominent location on the website that specific page that's associated with that one facility? Is that what you're thinking?
Yes, and in fact, let's go to the language let's go there. And I think that we've addressed that issue.
I think we have too. I just wanted to clarify that's your intent.
Yes, on page 20, on line 24, each individual long-term care facility.
Okay, great. Well, thank you so much for bringing this, and I think this will be good for providers and consumers alike. Thank you.
Thank you.
Representative Robichaux.
Yes, Representative Smith, and again, I thank you for bringing this. And what I also like about it is that it also gives those family members who may not be within the city to see the signs in the building, but have some concerns or they're not getting their questions answered, either they're out of state or even out of the city, that they then can look on the website and have that place to go to get assistance and help. So it's not that true physical, because not everyone. Many of us have relatives all over the country now, so I think that's going to be a good thing, too.
Absolutely. That's the intent of the bill. Thank you.
Representative Allen.
Representative, thank you very much for bringing this bill. I just want to acknowledge on International Women's Day, on line 19, your inclusion of the word "or her."
Absolutely.
So thank you for cleaning up the language for that as well, sir.
That is the work of Legislative Council. I appreciate them as well.
Are there any further questions from the committee? Any further questions? It's good to have a simple one, isn't it? All right, no further questions, then what is the will of the committee? All right, we have a move to do pass. We have a second. Any discussion? Any further discussion on this bill, 9073S? All right, all in favor? Aye. All opposed? And this bill has passed.
Thank you, Mr. Chairman. Thank you, committee. Thank you.
This committee is adjourned.